is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we're offering 5 conversations from episode 21, our review of the updated clinical practice guidelines from EASL, EASD, and EASO, with Louise Campbell and co-authors Elisabetta, Bugianesi, and Frank Tacke. Plus, from the vault, a discussion from 2023 about clinical care pathways. This conversation starts at drug therapies and goes on to cover an array of issues. In response to a question from me specifically about pharmacologic issues, Frank states that one benefit of the CPG is the clarity around the point that optimal treatment for a comorbidity must involve thinking holistically about the liver in the overall metabolic context of diabetes, obesity, cardiovascular, etc., rather than just thinking about it as a standalone organ. Elisabetta notes that while no drugs are efficacious for cirrhosis, the guidelines do report that some drugs are safe for these patients, although sometimes with adjusted doses. Frank concurs that the document provides guidance on managing patients with end-stage liver disease and also discusses how to manage cirrhosis and its various complications. Elisabetta that these could be the most difficult patients to screen for HCC because, as she puts it, the fatty liver is sort of foggy and therefore makes ultrasound and some other techniques difficult to use. This leads Louise to discuss a point that rises frequently on this podcast, the positive value of simply stabilizing disease through medication and lifestyle rather than pursuing an active regression. I add that many primary care physicians in the U.S. find managing metabolic, multi-comorbid patients confusing and frustrating. These guidelines, with an integrated vision of metabolic diseases and the idea that stabilization might be a sound strategy, simplify that perceived task. Louise suggested these guidelines, and I quote, pinpoint a role of the potential future for nurses who can support the entire cardiometabolic syndrome. As she points out, even hepatology nurses are, and I quote, not good at fatty liver disease. She said that on other episodes previously. This document might actually drive a curriculum for such a specialization in cardiometabolic or cardio-hepatometabolic. As Louise and I each comment at least twice during this episode, these guidelines are exceptionally impressive in terms of their scope and forward-thinking recommendations. Hopefully, this will energize you to review the actual guidelines, for which there's a link in the article write-up on the Surfing the MASH Tsunami website. Each conversation is uplifting in its own way, so just sit back, listen, learn, absorb, enjoy. And when you're done, join the conversation in our LinkedIn discussion group. Is there anything particular about the pharmacologic besides what we've already talked about that you'd like to mention?
Frank Tacke.
The pharmacological therapy, I guess, like one important aspect we would like to highlight is that the comorbidities need to be treated in an optimal fashion, in a fashion that considers the liver disease, the activity and the stage of the liver disease. Meaning that, for instance, if you have already type 2 diabetes, we know that combining metformin with GLP-1 receptor agonists like semaglutide or the co-agonists like tirzepatide, which is a GLP-1 receptor agonist, GIP agonist, is very useful because it reduces cardiovascular risk, also in the non-diabetic population, at least in at-risk individuals, and it lowers the weight. It helps people reaching the weight loss goals that you set for the patients. Also to treat dyslipidemia with statins, to use these weight-lowering drugs for obesity treatment is very important to consider when you manage individuals affected by MASLD. I guess the really new thing is that we have for the first time also a specific MASH targeted therapy that we can recommend, which is resmetirom, if it's locally approved and if it's within the label, which of course we do not know for all healthcare settings at the moment.
Elisabetta Bugianesi.
And one important thing is, although we do not have specific drug for people with cirrhosis, nevertheless, we can say that some drugs are safe, such as GLP-1 receptor agonists or such as statins, and can and should be given to these patients. Usually diabetologists give insulin to subjects with cirrhosis, but there is no need, unless it is a decompensated cirrhosis, to give insulin. All the other diabetes drugs, particularly GLP-1 receptor agonists, are good and safe and can improve some of the features that in some ways sustain the further progression and decompensation of cirrhosis.
Yeah, you find in the guideline like a whole range of how to manage pharmacotherapy in end-stage liver disease, which I guess is very important because also like lifestyle recommendations need to be adjusted. So all doses and treatment for the comorbidities need to be considered and possibly adjusted. In case of liver cirrhosis and compensated cirrhosis, is usually very safe to continue the drugs with a really cardiometabolic benefit. But of course, in the lifestyle situation, a moderate weight reduction, high protein intake, and then physical activity to maintain muscle mass in an individual affected by liver cirrhosis is very important. And dietary recommendations need to be, of course, adjusted to that. And Elisabetta has already pointed it out how important it is to look in this population with cirrhosis for complications of portal hypertension, which would mean, for instance, varices, and complications related to the malignant transformations, so surveillance for hepatocellular carcinoma. And I think, Elisabetta, it was mainly your chapter, like pulling all the evidence together, which is, of course, sometimes difficult to do the ultrasound surveillance for hepatocellular carcinoma, right? We had lots of discussions how to manage that optimally.
Yes, actually, those are the most difficult patients to be screened for hepatocellular carcinoma because the fatty liver is a sort of foggy liver. Mm-hmm. I mean, ultrasound cannot see all the lesions that happen in that liver. And unfortunately, hepatocellular carcinoma is one of the most common complications of these patients, particularly when the patients have also type 2 diabetes, because they are synergic factor to promote the development of primary liver cancer. So we suggest to include also alpha-fetoprotein assessment, and in high-risk cases, so with multiple comorbidities where the liver cannot be explored by ultrasound, to use a second-line imaging procedure such as MRI.
Louise Campbell.
I'm not the one to talk about pharmacology, but I think what we hear time and time again from all of the patient organisations and MASL is this stabilisation of disease to slow down progression. And I think these guidelines set that. If you were new to the field and you were an endocrinologist, by maximising all of the medications around to maximise that patient's care, then we are looking at slowing down progression. We're looking at the best evidence that we've got at the moment. And I think, again, that is a very big strength from the document, is this ability to maximise the treatment that each one of these individuals gets to maintain, slow down progression, and particularly for those that we can reverse. And I think it's very clear. It is, you don't get much later than the changes that Frank and Elisabetta have described within a month of the publication of a guideline to be that key. And I'd hope the rest of the European local societies like NICE for the UK will have to redo theirs, and ours are 2015. I'd like to think that we will utilise these and any future evidence that comes. So I'd love to see it built on, but we'll have to see what the UK decide out of the guidelines.
One of the things I found really impressive about this document was I once, about a year and a half ago, I had a primary care physician in the States describe the process of managing a multi-metabolic comorbid patient as being a little bit like juggling, because you've got 4 things up in the air at once and you got to figure out how to keep them all moving while you treat the patient. I thought this document did a really nice job of putting everything in the context of everything else, so that instead of feeling like you were juggling, you might feel like you could put them next to each other on a table and just sort it out, which I thought was really excellent and to be commended.
I'm just going to say one more point on that. I think the document also really pinpoints for me the role of a potential future role, cardiometabolic nursing, whereby you have nurses within the multi-specialities who bring that management together. So we're not just talking about endocrine nurses or diabetes nurses or hepatology nurses. We're good at hepatology. We're not good at fatty liver. We're better at the end stages when they're in hospital with hepatology complications. So we're moving out towards specialities that all of these areas aren't specialised in currently. But these guidelines allow me, certainly if I was to put a job description together, to say what I can see in that allied health role that can be the coordinator of the patient with these diseases. So those are the advantages that guidelines that are this modern and this related to evidence allow now for that building of those future roles that are going to be intrinsic as to how this disease progresses in its management.
Yeah, absolutely. We also have one chapter that is more like general about treatment, and that applies to pharmacotherapy, to lifestyle changes, to bariatric procedures. How do you monitor treatment success? So which of the markers that we actually measure would indicate to us that we reach this, as you described it, as stabilization or not progressing, stopping the disease, halting the disease, or even reversing reversing some of the phenotypes of the disease. And we try to put all the evidence together. And I like your idea of putting this a bit in the hands of specialized cardio-metabolic hepatological nursing, where kind of specialists that understand the patient needs very well, but also have the holistic view on the different disease phenomena or aspects to actually use the guidelines to promote this concept. I like this very much, although we still have some question marks regarding which are the best markers to monitor. And in the end, at the moment, I guess it's a mixture of several markers that would help us to really say, okay, we are on the right track, we are succeeding, or we are kind of going downhill. We need to intensify our efforts to manage the individual.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, Jeff Lazarus will join us to discuss the Healthy Liver, Healthy Lives initiative. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.